Okay, so as Ms. Grimes said, my name is Amanda. I am a master's student at King University. Love the program over there. Walter State set up a great transition process to BSN, MSN program over there. I'm going to be talking about obstructive pancreatitis within the pancreatitis lecture as a whole. There are a few parts in here that are specific to obstructive pancreatitis, and I'll kind of try to clarify which ones are specific for obstructive and which ones relate more to general acute pancreatitis, okay? Okay.
And you graduated from the Walter State, did you?
Yeah.
Yeah. So she's a Walter State graduate. That's exciting.
Okay, so before we get started, real quick, does anyone here at this campus or maybe in Greenville work in a hospital setting currently? Okay,
Yes.
a few hands. Okay, so have you guys ever taken care of pancreatitis patients before?
Yes.
Okay, if you have, what is the most often thing you'll hear nurses complain about or make mentions about when caring for these kind of patients?
Pain meds.
Right. So they're going to be like, oh, got to go give another dose of Dilaudid. Let me pull some more Phenergan. Oh, they're trying to drink water again. Got to go tell them about their MPO status again. So those kind of things you will have to be prepared for these patients. But you always have to remember to keep a sense of professionalism as a nurse caring for these patients. Although you might have people, gosh, they're just on their call light all the time. All they want is pain meds. That pain is realistic for them, and you can't really measure someone's pain. It is definitely a subjective, the sixth vital sign. It's subjective to each individual. So before we begin here, I've got a few QSEN essentials. I'm not sure if you guys have heard about QSEN competencies before. It stands for Quality and Safety Education for Nurses. We use these essentials a lot in the BSN and master's programs at King University. So this is just saying that during the lecture, we want you to be able to incorporate multiple dimensions of patient-centered care through coordinating care with other team members, assessing physical comfort, and providing patient education. We're going to discuss the importance of thorough assessment of pain quality, providing treatment for that pain, and evaluating the success of our treatment for their pain. And we're also going to examine our responsibility as nurses in assuring safe patient care coordination, patient communication, and patient involvement in their own care. So first, before we begin, what is obstructive pancreatitis? It can be known as any of these three names: obstructive pancreatitis, gallstone pancreatitis, or obstructive jaundice. The main reason for this is because it is a multi-organ involvement disorder. So on the top, that picture is a dissected pancreatitis. On the bottom left is the gallbladder, which looks very painful. And the bottom right is a liver. So in your textbook, it says that whether the cause of an obstruction is within the liver or outside of the liver, the main process that's going on here is that bile cannot flow normally into the intestine, becomes backed up, and ends up in the liver, okay? So to cover the pathophysiology, we've got a good display of the liver, gallbladder, and pancreas here. You can see that the common bile duct connects the gallbladder to the pancreas and also connects the gallbladder to the liver. So what happens here is that the common bile duct is obstructed. There can be various different causes of obstruction. You can have a gallstone, inflammatory processes, a tumor or malignancy, or pressure from enlarged organs. So like we said, it does involve multiple different organs: the pancreas, the gallbladder, and the liver together. What happens here is that the bile acid synthesis is decreased and the patient has increased cholesterol synthesis in the liver. So what that forms is bile that is saturated with cholesterol. So that cholesterol kind of settles out of the bile and forms our gallstones. So after those gallstones form in the gallbladder, they can travel down into the common bile duct and cause the original obstruction. So that keeps the bile from flowing into the pancreas, and the pancreas would then put it into the intestine to help break down fat and things like that. So when it can't flow normally through the common bile duct, it kind of backs up like a dam and backs up into the liver. So the liver then takes that and reabsorbs it from the common bile duct and redistributes it to everywhere else in the body. So some of the common risk factors, these are comorbidities that you'll see in your patients that come into the hospital with obstructive pancreatitis very often: liver cirrhosis and chronic alcoholism, like Ms. Grimes said. That's also very common in diabetics, people with hemolytic disorders, frequent biliary tract infections that can cause scarring of that common bile duct, gastric disorders, or recent bowel resections. Of course, those patients have dumping syndrome, malabsorption syndromes. So women are actually 2 to 3 times higher risk versus men for obstructive pancreatitis, especially women that are over 40 years old, multiparous, which of course means that they've had multiple children, and obesity. So you can also see this in some patients that are taking hormone-based oral medications like oral birth control or estrogen replacement. So what are we going to look for in our patients that might come into the hospital with obstructive pancreatitis? Some of these are related to more severe forms of obstructive pancreatitis. When you're assessing their abdominal pain, they're going to have very vague abdominal pain. Sometimes, like Ms. Grimes said, it'll radiate to the back or to the right shoulder. In severe cases, you may even be able to palpate a mass in the right upper quadrant. That will be their very inflamed and very angry gallbladder. So in severe forms of this obstructive pancreatitis, you can see jaundice, which is that classic yellow stained skin, mucous membranes, the whites of their eyes, and they're going to be extremely itchy in severe jaundice cases. So their urine is going to be very dark orange colored and frothy. They might have light tan or clay colored stools, GI upset and dyspepsia, of course, intolerance to eating foods that are high in fat, and of course there's no bile there to break down that fat, so that's going to cause a lot of GI irritation. As far as their lab work goes, usually in pancreatitis patients, the first lab that you're going to see elevated is those lipase and amylase levels. The more it affects the liver and causes jaundice and stuff like that, you're going to see increased liver function levels, the AST and the ALT, as well as increased bilirubin levels in the blood. They're going to have very low levels of vitamins A, D, E, and K. So this is where we definitely have to watch our severe form patients with low vitamin K levels. Vitamin K is essential in the clotting cascade, so you can need to watch them for bleeding precautions, easy bruising, stuff like that. Okay, so quick Q&A session. What does bilirubin have to do with the appearance of these symptoms in these patients, like the dark orange urine, the jaundiced skin, or clay-colored stools? Why would the bilirubin cause that? Huh? Right, so when it backs up into the liver and the liver kind of reabsorbs it from that area and redistributes it, bilirubin kind of functions as a pigment, which, to say in gentle terms, gives our stool its characteristic brown color. So that's why the bilirubin does not go into the intestines, doesn't give our stool the characteristic colors that it should have. That's why it's light brown, clay colored. It doesn't have that characteristic brown color. The pigment instead is going to go to your skin and to your urine. So the deposits in your skin are going to turn it nice highlighter yellow, and dark orange urine. Of course, those deposits are really irritating to the skin. That's why they'll be so itchy. So why would there be issues with these patients' absorption of vitamins A, D, E, and K specifically?
Those are your fat-soluble vitamins.
Exactly, perfect. They're fat-soluble vitamins. We don't have any bile present there to break down the fat and absorb these vitamins. So the fat and the good vitamins we want go out with the stool, causing our steatorrhea, and we don't get the vitamins that we need that are in the fat. So when you have these patients, what is an appropriate way to assess their pain level, and what might hinder you from assessing their pain or being an advocate for their pain control? What makes you maybe a little squeamish to call the doctor and say, hey, their pain's not really controlled by this hydrocodone? What kind of makes you guys a little uncomfortable with that? Anything? So these patients may be chronic alcoholics or Physicians may relate their pain to alcohol withdrawal symptoms if that is in their history. The main thing that we do as their nurse is to advocate for their pain needs. So sometimes the physicians can be reluctant to order pain medication for these kinds of patients. All we can do is be their voice to their physicians, let them know, hey, they're not tolerating their current pain regimen. They need something a little stronger, something more appropriate for their pain levels. And as they change their orders, you can implement them and reassess. If they're still not working, keep reaching out to the physician, okay? Any questions so far? Okay. So when we're diagnosing these patients, the number one diagnostic method for obstructive pancreatitis specifically is the abdominal ultrasound. It is 90% accurate. I'll just remind you, the number one diagnostic for acute pancreatitis is increased lipase levels. So acute pancreatitis is kind of this umbrella term, and obstructive pancreatitis, we're going to be looking for a cause of that acute pancreatitis, okay? Great thing about abdominal ultrasounds, there's no radiation or contrast solution involved. You'll definitely need to remember to educate your patient to be NPO overnight or at least 8 hours before the scan's done. We have gastric juices and food in the way. We're not going to be able to see what we need to see. Abdominal x-rays are used for abdominal pain. They're better for ruling out other causes of abdominal pain versus obstruction by a stone or something like that. There is radionuclide imaging, which unfortunately causes exposure to radiation for our patients. We definitely want to avoid that at all costs. There is oral cholecystography, which unfortunately does require iodine contrast, which we would remember to assess our patients' allergies and kind of tweak that diagnostic test as needed. So the one I've got here in bold with a star beside it is what I personally have seen most frequently in the hospital setting, the endoscopic retrograde cholangiopancreatography. Try writing that on a consent 5 times fast. Yeah, and they don't allow abbreviations on consent forms, unfortunately. So with the ERCP, this allows the doctor to go into the common bile duct and get direct visualization of any type of obstruction via fluoroscopy. So while they're in there, they might possibly extract the stone if it's small enough. They could take a biopsy of any weird tumors or obstructions there, or if that common bile duct is really small, like with frequent biliary tract infections, they might not be able to complete the ERCP procedure at all if it's very, very tight in there. So this is a picture from an ERCP camera. These lovely little nodules in here, those are very bad gallstones. And you can see the tissue's very, very red and angry from that irritation there. So as far as treatment for these patients go, like Ms. Grimes said, bowel rest is most important. We're going to have them NPO, nothing to eat or drink. In severe cases, they may have an NG tube with low intermittent suction. I have not seen that personally, but I do know of patients in like the critical care units that do have to have NG suction for a couple weeks at a time. So along with this bowel rest, we're definitely going to need to remember to give them fluid hydration. Sometimes they'll have normal saline. Most of the time it'll be LR, so they can get those essential electrolytes replaced. Let's see. So when the symptoms start to subside, they're having less abdominal pain, less nausea and vomiting, we are okay to start advancing their diet a little bit. The first advancement that physicians are going to make is putting them on a low-fat, clear liquid diet. As far as pharmacologic options go, our main focus as nurses, pain control, nausea control. Severe cases with frequent infections, they may get antibiotic therapy as needed. Physicians may choose to give medication to dissolve the stones if they're small enough. This medication is called ursodeoxycholic acid, or UDCA. I've never given that personally, but the stones have to be very small and made up of specific components for that medication to work properly. For long-term treatment, they may choose to put patients on bile acid sequestrants to lower their cholesterol levels long-term. And in severe cases, they do have to start pancreatic enzyme replacement, the Creon pills. They'll start that to replace the pancreatic enzymes that they're not currently getting.
I had a question.
Yes.
What's the difference between a clear liquid diet and a low-fat clear liquid diet?
No fat what? Liquid?
Yeah. I guess just the clear liquids would be low fat in content. Not sure.
Yeah. So, let me see.
He's asking the difference between clear liquid, like regular clear liquid, and low fat clear liquid.
I've never had a low fat clear liquid diet, but usually they're drinking like water. They can have tea. It's not got a lot of sugar in it. It's gonna be your basic clear liquids. But low fat clear liquid, I've not. We can get back to you on that. We'll look that up and I'll post that out there for you guys. Okay, so we can answer that question.
Okay.
Thank you.
You're welcome.
So some of the non-surgical options for these patients, unfortunately, most patients do not require surgical intervention for this diagnosis. What are some of the holistic options that we can offer to our patients? That's a good one. Spiritual support. Unfortunately, the hospital does not offer acupuncture. That's very unfortunate. So we can offer spiritual support, or like Ms. Grimes said, diversional activities, maybe give them some puzzles to work on, or like coloring sheets, or just sitting down and talking with them through their pain control methods. Ask how they deal with this at home. If they have any like therapists that they need to speak with. Some people do prefer like religious actions, and you can take that and go with what you need to do if they request presence. So some of the other non-surgical options, intracorporeal lithotripsy, they'll go in kind of like that ERCP, and they'll take out the stone if it's small enough with instrumentation. Extracorporeal shockwave lithotripsy, this is a lot like how they bust up kidney stones, except they're going to be busting up the gallstones. They call that process fragmentation, so that it can be broken up into small enough fragments to pass through that common bile duct on its own. If those don't work, in severe cases, they will get a cholecystectomy. Depending on the severity, it can be either laparoscopic or open. These surgeries are not performed until after their acute symptoms have already resolved. So much less pain, much less nausea and vomiting. For your patient education, tell them to expect extreme nausea and vomiting after this procedure. Some of the laparoscopic cholecystectomies, they're done as an outpatient procedure. They'll come in, get their gallbladder taken out, and we'll wheel them out to the parking lot with barf bag in hand. That is one of the most common post-op symptoms that they have after gallbladder removal. So, as far as nursing implications go, these are what you can do for your patient on a nursing level that do not require physician orders. This is what you can do to make their stay in the hospital better for them and their outcomes as far as discharge better in the long term. So while they're in the hospital, make sure that we're educating about the purpose of being NPO, not just telling them, hey, don't eat or drink anything. Make sure you're explaining to them the purpose of bowel rest and how it will be beneficial for their specific diagnosis. Definitely advocate for their pain control and adjust it as needed with communication to the doctor to something that will be beneficial for them. And of course, nausea and vomiting relief. You'll probably get a baseline order for Zofran. If that doesn't work, definitely go for the Phenergan. They have pills, IM shots, and IV piggyback if it's absolutely necessary. The main point is to be a fantastic patient advocate for their hospital stay. You're the voice for them to their physicians because they really don't have very much contact through the day, unfortunately. So if patients do need to undergo surgery, like I said before, we're going to educate them to expect the nausea. So they'll know beforehand. We obviously know beforehand so that we can get medications if needed. After their surgery is done, they'll follow the dietary restrictions ordered by the doctor, usually from clear liquids to full liquids, GI soft, and then back to regular diet. Most of the time, patients are discharged by the time they reach GI soft. Our advocacy here, if the patient is not tolerating their dietary advancement, communicate that to the doctor immediately. If they're not tolerating GI soft diets, let them know immediately. We'll back off to full liquid until they're ready to advance again, okay? Now for their discharge, this is for their long-term management education. Make sure that they know about their dietary restrictions. We're going to be avoiding fried, greasy foods, very spicy foods, to stay away from that. Dairy products such as cream and cheese, gas-forming veggies like broccoli, cauliflower. Definitely want to advocate for alcohol abstinence. No alcohol for these patients. Or if they must, very little controlled intake. If your patient is started on cholesterol medication or their pancreatic enzyme replacement, make sure that you're teaching them about their medication and encouraging their compliance. Of course, I'm sure you guys already know those pancreatic enzymes. Don't open it up. Don't get it on your lips. It's going to be a bad time, right? Also, make sure that you're teaching your patients when it's appropriate to seek their primary care provider versus emergency services. So I might tell a patient like, hey, if your pain medication isn't adequately controlling your pain, if you're having persistent nausea and vomiting, reach out to your primary care so they can get you checked out in the office, maybe tweak your medications if needed. Emergency services, you're telling your patient severe onset of sudden severe pain in your abdomen, if you're throwing up or passing any blood in your stool, any difficulty breathing, of course, sudden chest pain, they're going to come back to the ER immediately. Don't walk into your primary care office throwing up blood all over everywhere. It's not cool. All right, these are my references here. Notice that the top reference is your guys' textbook. Just FYI for you. Thanks for letting me teach for you guys. I think the next lecture we'll be doing is hepatic together. Let me know if you have any other further questions. I'll hand it back over to Miss Grimes, okay?